Oh my gosh. I am so excited. You can't even believe how excited I am here tonight looking out at all of you. We didn't know what to expect, did we? But good evening and welcome. As I look around this room tonight, I do see something I never dreamed that I would see in the 25 years with Pure Romance. I see a group of empowered women gathered together, learning more about their health, their bodies from experts that are specializing in sexual health. Really, how cool is that? Believe it or not too long ago, this evening might have never happened. You see, the research wasn't there, the knowledge wasn't there, and I knew too many women who were going to their physicians and coming home with no answers. I started Pure Romance to empower women so they would understand their bodies and embrace their sexuality. And as the company grew, the sexual health questions I heard became more complex. And it became very clear to me that something needed to change. That's why I started the Patty Brisben Foundation for Women's Sexual Health. After all, sexual health is something that affects every one of us different times of our lives. Whether it's a pain disorder, the effects of menopause, or even finding your way back to intimacy following a cancer diagnosis. This evening may not be about you right now. Maybe it's meant for someone else. Maybe it's meant for your mother, your sister, your best friend, or maybe your future self. As a woman, we owe it to ourselves to seek out sexual health knowledge, stand by one another, and always speak up and speak out. I'm proud of the difference that the Patty Brisben Foundation has made for women, especially in the areas of women's sexual health. To date, we have raised over $4 million for research and education. Thank you. And tonight, I'm excited to have you with me as we launch a new program for the foundation, #Sexual Health Matters. Thanks. Hey. The speaker series will begin educating and conversation to local women in partnership with top health professionals from across the region. Thank you again for being here and taking important steps in owning your sexual health. Now, before we get started, let me introduce you to this amazing group of women, our sexual health experts. 3 of these women actually set the board for the Patty Brisben Foundation for Women's Sexual Health. Dr. Sarah Bartlett, gynecologist with Somi, Javaid and Associates. You want to raise your hand and let them know? Emma Schmidt, certified sex therapist with Emma Schmidt and Associates, Sex and Relationship Therapy. Dr. Heather Pulaski, gynecologic oncology with UC Health. And last but not least, Dr. Janelle Evans, urologist with Kettering Health Network. And I'm thankful. I'm thankful for each and every one of you because we wouldn't have this platform tonight if it wasn't for you, so thank you. Well, let's get started before I get real emotional. And we're going to start the conversation off with Dr. Bartlett. Can you briefly tell us why you're so passionate about sexual health and what specific topics would you like to address this evening?
Okay. I was thinking about this today because I've been doing this for a little bit, and I love my job. I love being a gynecologist, and there's certain aspects of it that are more fulfilling than others, and sexual health is one of those. So I thought back to medical school. Somebody asked me if I was a thinker or a doer, which ultimately led me to gynecology because you do both. specifically sexual health. And the reasoning for that is women's sexual health concerns are complex. They are multifactorial. There's a reason there's not a Viagra for women. It's just not that simple for any of us. So I like thinking that through and working through the problems, the relationships, all the contributions. It's manageable, maybe even fixable. Some of the problems that we deal with, there is help out there. Whether or not you realize it, there is. I really enjoy that. It's uniquely satisfying. Relating to women day to day, that's uniquely satisfying as well. I like being able to improve health, women's sense of self-worth, as well as their relationships. It's important work. My patients are really, really grateful. What more can I ask for? So, that's me. That's why I do what I do. When I think about the things that come up frequently in my practice as a general gynecologist dealing with sexual health, is everybody wants to know about hormones all the time. Are they safe? Are they not? What do you mean by bioidentical? Do you do bioidentical? Should I take bioidentical? So I always kind of start with educating people about that a little bit. So the term bioidentical is not a term a lot of healthcare providers use, because it's really more of a marketing term to try to get you to buy a product, frankly. So in terms of education, let me back up. Back in the 1960s, the doctor said, go on hormones, don't ask why, stay on them forever. That was just the way it was. And then 15 or so years ago, a big study was done on women, and when the study results came out, it scared everybody. It said, hormones cause breast cancer, oh my God. And so all the doctors said, come off your hormones, they're gonna kill you. So everyone went from being told to be on them, everybody come off, they're horrible. Well, it's not quite that simple. Nothing is for women. So it is far more complex than that. In the last 15 years, our data has come out to kind of elucidate who should be on them, when and how often and why. It's an interesting thing, and there are guidelines for that. There are definite pros and cons. Like everything else, it's complex, it's personalized. But being complex and personalized does not mean bad either. There's a distinction. For some women, they're potentially life-changing. What I tell my patients all the time is they talk about natural, and is it natural, and is that harmful because it's not natural? Well, my hair is supposed to go gray, and I refuse to accept that as an option, so it's about choices and using science. So I would encourage everybody to use caution. Talk to your doctor about this particular topic, as well as all the other ones we're going to discuss, but talk to true experts, people who truly have trained in this, have the expertise, are reputable, and have the experience to help you with your needs and answer your questions with time and empathy. That's what I got.
Thank you, Dr. Bartlett. All right. Emma Schmidt. Emma, we're happy to have you here tonight on the important topic of libido and desire. When women find themselves struggling with a lack of sexual desire, what are some of the common causes?
Yeah, so
we might be all night.
We need the whole night. I remember being in school, and one of my professors he did his doctorate, his dissertation on desire. And he said, it's so complex I couldn't figure it out. So that was not encouraging to my caseload. But what has happened is Masters and Johnson created this sexual response cycle. And it shows that desire happens, and then arousal happens, and then you have this excitement, plateau, you have an orgasm, and then you have this resolution stage. So it's pretty linear. Well, a few years after that, a lot of years after that, in around 2000, this woman, Rosemary Basson, came out and said, actually, I feel like female desire is a little bit more complex than a linear, you get desire aroused, you have an orgasm, and then you take a nap. So, so she went in and did research, and what we find is that desire is really caused by everything. It can be caused by your stress life. It could be caused by trauma that you experienced in your past. It could be caused by you being a mom and being exhausted at the end of the day, and all you want to do is hit the pillow as soon as it turns 7:30 and your kids are in bed. It could be hormones. It could be that we work closely together in combination with I send my clients over to Somi, Javaid and Associates and Dr. Bartlett. And what's important to me is to figure out what's causing what, and are there hormones that are creating some of the low desire pieces. So there could be some low testosterone that could be creating some of your low desire. There could be that you're in a routine and you feel stuck. You feel like you're doing the same thing. It's 9 o'clock. Your partner looks over and says, hey, do you want to have sex? And you're just like, okay, let's do this. And then, because that's what happens and that's what I hear about every day. And so there's no desire in that. That's just the act of sex. There's no desire that's happening there. It's just getting in and getting out. So desire comes from a lot of different places, and trying to access and figure out where it's coming from is important. But in that complexity, I think it's actually pretty simple. What I found is even if there's hormones involved, even if you're stressed, even if you have kids and you're exhausted, one of the main components for desire is connection. And so whenever I find that my partners are coming in, low T-score, low testosterone, they're stressed, that they have a full day on their plate, if they feel connected to their partner and they feel like their partner has been engaged with them throughout the day and has let them know that, hey, I really love you. Hey, I really want you. Hey, these are the things that I see in you. These are the affirming things that I want to say to you. My desire is going to increase, and I want to be near that person, even if I'm so tired at the end of the day, or I feel like I wouldn't necessarily have some kind of sexual urges. Desire is, I want to have sex with you. Coming home and just having sex is not desire, it's just doing the act of sex. So that connection with your partner is such a huge component, and I think that when I can dive into that with couples and individuals or whoever you might be attracted to, I think that is a huge piece, and a common factor with desire is that connection and bonded piece.
All right. Also, we know that you do a lot of work with couples. Can you talk about the difference between men and women when it comes to desire and libido?
Yeah. So there is a difference, but it's actually not that big of a difference. I think we as a culture have been told men and women are vastly different, and I think there's just a little piece to it, and that is about our stimuli, what we see and how our brain interprets desire, and the time. So Basan, this person who created a new idea of sexual response, that it's not so fluid, that it actually kind of looks like this. It's a little it's more of a cycle and kind of crazy than it is linear. She coined this term called responsive desire. So what she said was, as a society, we have learned to look at our partner and say, if I don't have desire like my partner does, that means I'm sexually dysfunctional, or I have low libido. What's actually happening is we might just be looking at the way that I experience desire is different than the way my partner experiences desire. So if my partner is sitting on the couch and we're watching Survivor and he looks over at me and says, hey, do you want to have sex? It's probably not going to be exciting for me, but I still might do it. Right? So for him, looking over at me and thinking like, wow, she looks really attractive right now. I really enjoy her company. I want to be able to engage in a closer connection. That would work for him. But for me, what she's talking about in responsive desire is there needs to be a little bit more in a longer period of time. So it might be, hey, let's turn off Survivor, let's talk a little bit, let's connect with what my day was like, use some empathy towards me, active listening, maybe some sexting throughout the day. So when there is active attention, I feel cared for, and some erotic talk, so maybe you create a fantasy through the day, maybe you do some like role playing through texting or through some kind of phone conversation, my mind starts to become more present with, oh, I'm interested in this. Like, he desires me and I desire him, and I'm thinking about it now, and now I'm excited to go home to connect with him. Or, wow, he's paying attention to me. I want to feel closer to him. And then that is how the difference is for women and men. For women, it just takes a little bit longer. For men, it can be a little bit more active, but what I hear for a lot of men too is, I don't just want my partner to come and have sex with me, I want to feel the connection too. And so I think both women and men are looking for the same intention, it just takes a little bit longer. So I think that education is actually really important, and when I can get couples or partners to know about that piece, it can be really changing too in terms of desire.
We could go on all night with that.
Yeah.
We're going to have questions. Save it, because I know it's going to be a good one. She's going to be here all night. All right. As we know, there are several causes for change in desire, one being how women feel following cancer treatment. At this time, I would like to have Dr. Pulaski offer insight on this topic.
Oh, I mean, cancer is obviously such a large word that means so many things, and I tell all of my patients I can't really give them advice about what next and answer the big questions, including about sexuality and their survivorship, without knowing the stage of cancer and the type of cancer, because cancer treatment now is a huge gamut, and we are so fortunate that we've come from the days of just get your affairs in order and talk to your family, maybe don't talk to your family about the diagnosis, to a whole gamut of treatment, and now to even focus on survivorship issues. I mean, I think even a generation ago, the concept was, you're lucky to still be alive. Maybe not how you're living is not how you would want to keep living, but, we're just glad you're alive, and we're not going to focus as much on survivorship issues. So we're so thankful now that we actually have long-term survivors and have an ability to focus on survivorship as such a key component, actually, of cancer care. Sexuality, though, I still feel is at the bottom edge of survivorship care plans. I mean, partly due to the time allowed that we have with patients in the office, the complexity of the discussion, and the differences in the treatments that, that we give. But when you look at the, small amounts of data that's out there, we know that it's a big complex issue for all women to have issues with their sexuality. Cancer patients, when they're age matched for an age control, it's about threefold higher in our women cancer survivors to have sexual dysfunction issues compared to their peers. And there's so many reasons for that. I mean, there's the arousal component, the desire component, the pain, body disfiguration, the psychosocial component, the relationship dynamic changes. I mean, we have a word now, part of the cancer survivorship concept, called cancer distress, which is supposed to actually combine, I think people think you should be depressed, you have cancer, or anxious, you have cancer. And that's not it. I mean, speaking from the other side of the chair and what I see my patients go through, it's multifactorial. There's the physical symptoms, there's the emotional symptoms, there's the spiritual angst, there's the financial and social concerns. All of that also has an effect on the sexuality that our patients experience both during treatment, and after treatment. And I still think there's a little bit of a stigma about discussing it, because patients are supposed to just move on and be a survivor and go back to life as normal, and life is just not normal in any sense after being told you have cancer, regardless of what the treatment effects are. So it is a huge problem with all of our patients, but the range of which problems predominate really do depend on the treatment, the type. I'm a gynecologic oncologist, so I have a lot of cervical cancer patients that have had extensive radiation, and so for them, the vaginal narrowing and the dryness and the premature menopause from radiation might be their biggest component. But for a breast cancer patient, it might be the premature menopause brought about by the chemotherapy, versus a patient with a stem cell transplant might have oversensitization from graft versus host disease. So there's a huge spread of potential problems, and a lot of things then you can also do for it, but the data is still limited, and there's not a lot of good research out there looking at interventions in cancer patients. So we're hopeful now the tide will continue to turn.
Amazing. I mean, tell me, are these doctors amazing? Yeah. Thank you. At the root of many concerns facing women and their sexual health is the issue of pelvic pain. Dr. Janelle Evans sees this with her patients every day. Dr. Evans, what are the more common causes of pelvic pain?
So this is, well, I'm not going to say it's one of my favorite topics because it's extraordinarily complex. However, I can say that I saw 11 new patients today, and seven of them came in for some issue involving either bladder pain, vaginal pain, generalized pelvic pain, endometriosis, tons of different reasons. And the best part about this topic and this panel is that it actually brings everything together in a certain sense. I mean, what Dr. Bartlett was talking about, I mean, just, general gynecologic issues that are around sexual dysfunction. What Emma was talking about with desire and pelvic pain don't go together. So if you have bad pelvic pain, you're not going to have any desire. You're going to be afraid of having intercourse. You're going to be afraid of really doing anything intimate. And then some of the issues involving malignancy and your life after it also are incorporated in that. And what I brought was a little bit of a prop, because pelvic pain is such a massive issue. So I looked up on UpToDate, which is one of our, easy reference things as physicians. So, if you're just like, I've never heard of that, what should I look it up on? You look on UpToDate. And it's basically a giant encyclopedia of medicine. So these 4 pages are all of the things that can cause acute and chronic pelvic pain. So we're talking 4 full pages of diagnoses. The interesting thing about it is that you can think about the pelvis and the abdomen as being many, many different systems. So everything down there is kind of close together, right? So your bladder's down there, your vagina's down there, uterus, ovaries, rectum, lots of muscles, lots of nerves. And so one of the things that we focus on is where is the pain originating? And it's not necessarily going to be just one place. Like I said, pelvic pain is extraordinarily complex. So let's say you have a bladder pain syndrome, like interstitial cystitis, terrible chronic bladder pain syndrome. That in turn can cause other types of pelvic pain, such as muscle spasm in the pelvic floor. Lots of different things. Endometriosis, you have cyclical pain that is very, very difficult to deal with without a chronic hormone supplement or having your ovaries taken out, because that's ultimately the source of it. There's gastrointestinal issues that could cause chronic pelvic pain. So when you put it all together, there are many, many reasons why you can have pelvic pain, and every single organ needs to be evaluated to figure out what the root source of it is.
Can you share information on treatment options with our guests? And also, can you identify and address the difference between pelvic pain and bladder-focused pain?
Yeah, so a lot of what I do is bladder-focused pain. So I'll start with that because, so there are certain people that will come into our office and they say, I pee every 15 minutes. Like, I can't get out of the bathroom, and every time I pee, it's like a tiny little squirt, can't get anything else out, and it hurts really bad. That's a bladder pain syndrome, and there's a very large spectrum of it, and they all have different types of diagnoses. Bladder pain syndromes are chronic. They are really hard to deal with, and they are often associated with a lot of other things, such as depression, IBS, endometriosis, lots of other stuff. The problem with bladder pain is that once you have it, if you don't address it fairly quickly, you develop other issues. So you develop things like what we call levator spasms. So the whole pelvic floor is a giant bowl of muscle, and it is meant to hold everything up. So that is why, when you bear down and you have a bowel movement, your uterus doesn't fall out. If it does, that's a totally different issue, and yes, I can fix that. But if it doesn't fall out, then your pelvic floor is working and your muscles are working, and there are several sets of muscles. If you are in chronic pain for a variety of different reasons, those muscles go into spasm. When they go into spasm, you can't figure out a way to make it go away unless you have specific therapies. So one of the things, and I want to touch on this a little bit because it goes with pelvic pain in many, many different aspects, is pelvic floor physical therapy. which sounds wild. And many people are like, well, what the heck is that? Like, seriously, pelvic floor physical therapy, like, what are they going to be doing to me? But basically what it is a variety of relaxation techniques, biofeedback, stretches, different types of muscular massage, dilators, all sorts of things that go into fixing different parts of chronic pelvic pain. And especially with the muscle-related things, some of the bladder-related things, so being allowed to let your bladder expand a little bit more, you can actually do that through physical therapy. So that's the main one that we start to focus on. There's plenty of medications. There's different surgeries that you can do. You can do trigger point injections in pelvic floor, but almost always when it comes to generalized pelvic pain, we start with some sort of focus on physical therapy.
This information is so valuable, and we could be here all night talking. But right now, you're in the audience. I want you to realize this is a very safe environment to ask questions, and that's what we're going to do. We're going to get this started tonight. You've got 4 amazing panelists up here, so who would like to start the questioning?
Making the pregnant girl run around.
I know you were talking about desire. Desire is wonderful, but when you're my age and
Antique.
and my gentleman friend is older, I'm really lucky when it's hard. So desire sort of depends on the hardness. So, you sort of jump on it when you can. I'm sorry, I'm being blunt, and that's the way it is. That's it.
Did I not say this is a safe environment?
That's,
And the younger ones over there are like, oh my God, will this happen? Yes, it will. It will.
Yeah.
girls, let me tell you, 71 still works. He is 71.
We knew you weren't.
Yeah. But, I know the desire is still there, but it's hard to get everything else going. And if I didn't have my little dealer back here to help with the
who would
desire.
like to take this question?
I can answer that.
Okay.
Yeah.
So first, if you have the question, other people probably have the same question. So I'm glad that you're asking that too. So I don't know if I hope I can answer this, what you're asking. Whatever age, I think it's good to identify how do I feel desire. So maybe it's if he has an erect penis, if not, what else can we do? But one thing that I think is important is getting away from this idea of performance. So sex can only happen if there's an erection and if we have insertion and then if we have an orgasm, otherwise we've failed. And so I think it's really cool to say, how can we take time for some kind of sexual engagement, let's say an hour, where we just stimulate each other or do body caressing and get to know each other's, just explore each other's bodies, and that can feel really pleasurable and maybe satisfying to where you don't necessarily need the erect penis, you don't necessarily need an orgasm. But I think at 71, at 18, that advice I feel like plays to all age spectrums, yeah.
Can I add to that? So I do a fair amount of surgery, hysterectomies, and I always tell my patients, you're not allowed to have sex for 6 or 8 weeks or whatever the case may be. And they're always amazed when I remind them that they can't have penetration, but that doesn't mean they can't do things and be with their partners and have fun. And it's really interesting how that conversation always comes up, and it's a reminder that we are so focused on penetrative sex, which is great and we love it and we want to maximize that potential, but it's not the only thing with intimacy and sexual drive and satisfaction. So.
And maybe he might be, I don't know if it's the flaccid penis, but that still has sensation and he probably still experiences pleasure. It just might be that he's at a different stage. And so being able to explore, what is it like to stimulate a penis that isn't erect? Do you still experience pleasure from that? And how do we now utilize that? Yeah.
Hi. So you had a very thorough explanation on pelvic pain, and now I'm having anxiety. But no, I guess my question is, what is like the general age you see women coming to you for pelvic pain, and is it normal to see, how do I put this, like a virginal, non-sexual teenage girl experiencing pelvic pain and spasms?
Yeah, I mean, so pelvic pain happens at all ages. I have patients from 16 to 98 that all experience some different level of pelvic pain. And the time of life is going to be different for what kind of pelvic pain. When you're very young, I mean, there are certain things that are going to cause a lot of pelvic pain, endometriosis probably being one of the most common. And that's cyclical pelvic pain. So basically, a couple days before you get your period, all of a sudden, you can't do anything. You can't move. Everything is crampy. You're chewing ibuprofen, like it's candy, that sort of stuff. And then as you get older, there are a whole different realm of things that start happening. And then post-menopause, the most common thing is atrophy. So basically, you lose all your estrogen. The vagina essentially turns into scar tissue. If you looked at it under the microscope next to a piece of scar tissue, it's very difficult to tell the difference. And scar tissue has a very different level of sensation. It doesn't stretch the way that a normal premenopausal vagina stretches. There's a lot of different factors with age and what you're experiencing. But for younger people, I mean, it can be anything from the pelvic floor spasm, endometriosis, just being scared. Like some people are just afraid of intercourse, and they're worried that something's going to hurt, and then because they're worried of it, then in turn it does hurt. So there's a lot of different stuff in play. Also, bladder pain syndromes, interstitial cystitis, much more common in a bimodal distribution. So basically in your 20s, and then again, 40s, 50s, all of a sudden you see another bump of people who start having these painful bladder syndromes, usually starting with the UTI, and then it's a vicious cycle from there.
I want to add again, I like talking apparently. Find a doctor that really listens to you. Pelvic pain is a tricky thing, so if you're in an office that's too big, too busy, they're doing a wham bam pap, and the minute you have a problem, their hand's on the door, it's not the office for you. I really encourage you to find somebody who has the time and the right setting in their office to listen to that. Pelvic pain is a complex thing, but you have to talk to the gynecologist to figure out, okay, what's really going on? Is this gynecologic? Is it actually GI related? And you are in the totally wrong office, but somebody needs to steer you in that direction. Somebody has to send you to Janelle. I mean, if you don't know to go there, you're just going to think this is the way it is, and you have to live with it, but that is not the case. You just have to be heard.
I will say, too, just to add on to that, because although I'm an oncologist, we're also kind of the end ground in gynecology. When they can't figure out what, they send it to us, because that's just sort of what we do. And I actually see a fair amount of patients that come in with different ovary remnant syndromes, chronic pain, but one thing I think to explain to patients, too, a chronic problem is probably not going to be fixed in just one visit. So I agree with Sarah, finding a provider that you can have a relationship with, an ongoing process with, and really the understanding, I think we as a society overall, I mean, we'd love a quick fix. I'd like to retire tomorrow because I just fix your cancer with one little pill and it's gone, but things aren't always that simple. And I think hopefully the complexity of discussion here and the varied sundry issues maybe helps to bring to light that it's just not always something simple that can be addressed in one visit. So finding someone that you can relate with, that you can trust with. I mean, I love our pelvic floor therapists. I mean, it's predominantly who I send folks to when they come to me at the end of the road. I'm like, has anyone ever suggested you a pelvic floor therapist? And there's all sorts of, but people's minds is kind of closed to that because it seems intimate in a way that they're not really used to or accepting of, but just opening the mind to the concept, I think, is really, really crucial for any chronic pain syndrome, whether it's chronic pains after cancer treatments, chronic pain from gynecological conditions. I mean, it's not an easy fix, I guess I would say.
I've been with Pure Romance for over 13 years, so I have spent a lot of time in bedrooms or closets with women. Really educated myself, did everything I'm supposed to do, but I think the biggest problem we have is how do we get these women to find the right physicians. I'm here in Cincinnati. I know exactly where to go. You know, I know who to refer them to in this area. But what do they look for? What are the words they're looking for when they're looking for someone who specializes in, because they get in, they see a GYN, they dismiss them, and then they're done. What are we supposed to tell them to be looking for?
That I changed where I practice and how I practice a few years ago. And in doing so, people want to put up billboards and all this stuff, whatever. The overwhelming majority of my patients are referred to me by word of mouth. And I think especially among women, that is the biggest compliment to me, but that's how I find my dentist. That's how I find my hairdresser. I don't care what Facebook or Yelp or any of those things say. I want to know who my girlfriends, my coworkers, what really happens behind the scenes, not at the front desk, not when you call. I want to know that interaction. So trust your girlfriends. I mean, ask them, talk to them, and really talk to them. Ask the important questions. How long were you there? Do you feel like you were listened to? Were people genuinely kind to you and taking their time?
I think the only issue with that is that a lot of people don't talk about it. You know, and I think, you know, especially with pelvic pain, like nobody likes to talk about that. Nobody wants to like go out for, you know, a glass of wine with their friend and be like, hey, every time I have sex, it feels like I'm going to be torn in half. You know, like, I mean, like that's not how you start a conversation usually. Which is an issue, but if you have a good girlfriend and you know you can trust them with that sort of a problem, or if you have a great gynecologist. I mean, you know, if you're lucky enough to get to Dr. Bartlett, you know, rather than somebody who's just like, oh, well, you're old, you got to deal with it, you know, or something like that, you know, which I've heard way too much. People who finally get to me and they're like, well, I've been going to this guy for 30 years and they told me that, you know, it's just old and you're not supposed to have sex when you're old. So, you know, so many times, it's awful. And I'm just like, wait, no, you're supposed to have sex as long as you want to, you know, and you know, there's a disconnect there between, and it has to do oftentimes a lot with the busyness of the practice. You know, if you have 5 minutes with your gynecologist and all they want to do is get a pap and throw you out, like that's an issue. And chronic pelvic pain requires an initial consult and probably several other things down the line. It's not just a one appointment sort of thing. You're not going to get, you know, answers and a solution with one appointment. So.
And all of us, the true experts in this, you could really find if you investigated. You want board certified experts. You want people who have some credentials behind them, actual credentials. So there's websites and things you can look up. There's like the North American Menopause Society. There's the American College of Obstetricians and Gynecologists. These are credentialing bodies that put the stamp saying, okay, you're legitimate. So if you really want to do your homework.
And if somebody doesn't have something about sexual health or pelvic pain on their website, don't go to them.
Yeah.
I mean, it's, you know, like most gynecologists, if you're listing, you know, here are the things that I like to do, you know, in urogynecology, which is what I do, you know, here are the things that I specialize in. If it doesn't say pelvic pain in there, that's not the person you want to go to.
For sex therapy, you can call yourself a sex therapist without any training at all. And so that can be really challenging. So looking for someone who is certified, who says they're a certified sex therapist is really important. And so that piece of information can get you to someone who's qualified versus someone who is interested in talking about sex with their clients, which is great. It's great to have people who feel really comfortable, but finding someone with that training is also important. So looking for someone who's certified as a sex therapist and not someone who just calls themselves a sex therapist too.
I think that this question is probably directed to Dr. Pulaski. I was diagnosed with stage 3 breast cancer. However, I just wanted to know if you had a lot of patients between the ages of maybe like 25 to 35 or so forth that were, you know, diagnosed with an extreme case of breast cancer, HER2 positive, double mastectomy, forced into kind of a hysterectomy, extreme chemotherapy and so forth. If you had a lot of, you know, women amongst that age that came to you and asked you specific questions because they don't really give you a lot of information. I mean, I'm thankful enough to work for this corporate office, so at least I can, you know, I know a little bit more about how to find answers as opposed to somebody who probably would not know, or, you know, the questions that may come at such a young age when they have to suffer from such an awful disease and experience not having the opportunity to have children and so forth.
No, we get a lot of patients. I mean, I don't treat breast cancer personally, but this is where my gynecologist training or perspective comes in, because most of the doctors that I work with are other cancer specialists, surgical oncologists, hematologic oncologists, and they'll come to me because they'll have patients in their office with these complaints and they don't really know who to send them to. They don't have the background in their training as a gynecologist to know how to address this question. And so it is a common thing. I mean, obviously, as you know, breast cancer, especially advanced breast cancer in a younger patient, while more common maybe than it used to be, is still not what's most common. And so finding folks out there that understand the gamut of young cancer survivorship is very, very different maybe than dealing with like older patients. But the one thing that I like to try to pride myself on is having the resources that even if I don't understand what the best option is to help that patient, I mean, I do keep up with the data on hormone replacement in breast cancer patients and vaginal therapy options for breast cancer patients and patients with prior radiation, but I don't prescribe a lot of that alongside the chemotherapy and other things that I do, but I do know the resources like Dr. Bartlett and Dr. Evans to get patients to, and I'm not afraid to talk about sexuality and a cancer survivorship like concept. And so there's a lot of different treatments out there. I mean, oncofertility, or dealing with the fertility concept of cancer, really needs to start when the cancer is diagnosed in anyone of reproductive age. And that's something that, again, also I think has been not as high on the list. You've got like this life-threatening cancer, the future baby that you thought you might have is lower on the totem pole. Yeah. Right, and so it's like we really need to address that at the beginning. We have an excellent oncofertility program through UC. A lot of, I think, of our REI colleagues are really starting to embrace the concept and understand the science. And the science, I think, for infertility treatments quickly, because that used to be the problem with cancer patients with fertility issues, is that you would have to delay your cancer treatment in order to try to preserve your fertility. And when you're looking at your life versus, the potential for children, it doesn't matter if you're not around to be here. So that was always the idea, but now they've got it much tighter in terms of the time frame in which they can do fertility sparing options and allow patients to have that. But I think it's very appropriate also to address that same concept even on the other side as a survivorship issue. Like, what are your options? Like, what are your choices, both from a family standpoint and a relationship standpoint, a sexuality standpoint. It's not as clear cut as like, you've had breast cancer, you can't take hormones, sorry that happened to you. It's not that clear cut, and there's very good data and concepts in the non-cancer patient prospect. And the problem that we have as physicians who are trying to be evidence-based and to allow for good care, you certainly don't want to be the one that compromises patients' cancer outcome by prescribing the wrong drug or moving forward with the wrong option, is trying to apply what we know in non-cancer patients and take it into our cancer patient population. Because as you know, everybody with cancer, even breast cancer, the treatments are all very different, the ages of patients is different, the estrogen risks are different. So even trying to group those patients into a big prospective study, it's hard to do, and there's probably not a lot of money in it for the companies, and there's not a lot of process to do it. And so we're always trying to abstract. And so I think having someone who thinks outside the box, who doesn't just say, oh, you've had breast cancer, you can't take hormones. I mean, I see a ton of BRCA patients or BRCA positive patients in my practice as a risk reducing strategy. And I can't tell you how many of them, I have to take their ovaries out from an ovarian cancer risk reduction. They've also had a mastectomy, and they'll go back to their gynecologist who declines to prescribe them any hormones for replacement after the prescription I've given them has run out, because they might get breast cancer or they have an increased risk of cancer. And I'm like, well, they don't really have much natural breast tissue. But even if they did, hormone replacement is safe in that patient population, and there's good data to prove it. And so people are just scared, and I don't think it's doctors that are actually acting out of ignorance. I think they're acting more out of fear. Mm-hmm. Nobody wants to be the person that takes a beautiful breast cancer patient and causes something, and then they have a recurrence, and they say, did I contribute to that? It's just safer to stay in the present and just acknowledge it, because after you walk out, you walk on with your survivorship, and they move on to the next patient, and that's just simpler. And so I think being able to talk about the complexity of it and acknowledge where we lack knowledge and acknowledge where we're going to experiment and what risks we're willing to take. I tell my patients, I'm like, you are the captain of the ship. Like, it's your body. Your priorities may not be mine. but I'm the navigator. I have the experience, the training, the board certification to be able to show you on the map where to go. But you have to make an educated decision, and patients now are so much more educated. You know, Dr. Google is good for some things, and you just have to find a doctor, I think, that will talk through those. But certainly, I mean, I see this, I think, an opening step sometimes to get patients with cancer to the other people that know way more than I remember about hormonal replacement therapy options and other choices, because I understand the cancer perspective. And so a team approach, I think, is the best thing we can offer these days in terms of cancer care.
Can I add to that? Women need to advocate for themselves, and I don't want to be that woman. I've tried not to, but the more I learn, the more I'm becoming that woman. Men still run the world. Men run the insurance companies. They still make a lot of the decisions, and that is changing. But women's healthcare is still behind men's in a lot of different ways. Research, application of it, knowledge, available resources. So we need to advocate for ourselves. We need to advocate for each other. Take what you've learned and advocate for everybody else. I would encourage you to take that and make something beautiful out of that. It may not have been the best experience. You've come out, I would hope, better in some ways, and share that. Use what you know. Absolutely. Good for you.
Right here.
I came in late, so forgive me if you've already addressed this, but I had some questions about Mona Lisa Touch. I've heard that it's effective for vaginal atrophy and menopause, and I wondered if any of you have had an experience.
I have one. Yeah. So our office does Mona Lisa Touch. It's actually it's one of those technologies where you think, so this guy from Italy, this tiny little guy, Salvatore, he came up with this idea that if you basically treat the whole vaginal wall with a carbon dioxide laser at a certain, wavelength and everything, that you will be able to remodel the tissue. And how he came up with that is just amazing to me. But the data behind it, and it's becoming more robust, and I mean, it's been approved in the US for 5 years now, in Europe for quite a bit longer. But basically, the technology behind it is it remodels the tissue on the inside of the vagina. So like I was saying before, how you have, essentially a development of scar tissue in the vagina after menopause, and whether that's surgical menopause or, chemotherapy-induced menopause or anything, the vagina is going to change into a different structure after the estrogen goes away. What the Mona Lisa Touch does is it applies a carbon dioxide laser in a little matrix. You start way at the top of the vagina, and then you move yourself out by a centimeter at a time. You do 3 different treatments, and basically the theory behind it is that by causing small amounts of damage, I mean, it's awful to say damage, but it's basically you're causing little laser marks in the entire vaginal wall from the top to the outside. And what that does is it stimulates new cell growth. For whatever reason, that new cell growth actually looks more similar to premenopausal vaginal tissue than the scar tissue appearance that forms after menopause. It's been proven to be about 90% effective. There's some great data about some other things that it can treat, like lichen sclerosis, which is a really horrendous dermatologic disease that tends to happen to people postmenopausally, but also premenopausally in some people. And there's a variety of different things that research is going on to see what else can this laser do. Mona Lisa is not the only one. There's actually several other lasers that have achieved FDA approval for atrophic vaginitis or lack of estrogen in the vaginal tissue. But Mona Lisa right now has the most robust data.
I was going to say, in my particular office, we use the Intima, which is just another brand of this similar technology. Part of my office, my partner does some aesthetic stuff, so it's like, feel good whether you're getting a pap smear or Botox or whatever. So they do some of the same technology for facial rejuvenation of sorts. That's been going on for a long time, so I guess they sort of applied how, celebrities and whatever else get their face done. Why not get your vagina done too? So, but it is, as Dr. Evans said, it is remarkably effective. We're doing some studies within my office, hoping to expand that knowledge and availability. Very, very effective when done properly in the right hands and on the right candidates. Not everybody's a candidate, and like Dr. Evans could say, some of these, like women come to me saying, oh, it's gonna fix my incontinence. Maybe, but sometimes you need to see her and have the real deal, so. Correct. So the other piece of it is not covered by insurance. So it is prohibitively expensive for a lot of women, and that is sad because it is very effective, and maybe with more studies it will be, but currently it is an expensive, indulgent thing for some women, but it is effective.
And the cost across the board is not consistent. So depending on what office you go to, you pay X $100 per treatment to, some places in Ohio are charging $1,000 a treatment, and you have to do 3. So, it can be very cost prohibitive for some people. I wish that insurance would hop on board and just get on the program, but so far they haven't.
This is where you need to make your voices really loud to make these changes.
Absolutely.
Anybody else have a question?
So I have a question about birth control. IUDs are kind of becoming more and more common. What is your experiences with those, and do you have any advice for women that choose to use IUDs?
So I'll start with that. I've had 2 of them. I am a huge fan of them. My patients will read things online and come to me and say, I heard it's this and it can cause this. I'm like, I've had it. I wouldn't do that if I thought it was going to cause weight gain or this or this or this. I'm a huge fan. In general, I see fewer problems with IUDs than I do birth control across the board, birth control pills. I think it's a really nice option. There's still a lot of misconceptions out there, but in general, it's an option for most women. One of the nice things about it in terms of sexual health is it goes in the uterus, it does not contain estrogen. There's a few different kinds. There's one that's non-hormonal, all the other ones are hormonal, but they're progesterone-based. The progesterone that is released is mostly localized, meaning you don't get a lot of systemic or full body side effects. That's a nice thing for women who have sensitivities to other hormones. One of the things that birth control pills oftentimes do is reduce sex drive. A lot of doctors aren't aware of that because they're trying to prevent pregnancy, trying to fix your periods, but you get a very undesirable side effect with that. The IUD is different in that sense. It does not affect sex drive for a variety of different reasons. But so when women come to me and they're complaining of decreased libido and dryness, they're on birth control. That's the first thing I can get rid of very easily and maybe fix the problem that quickly.
I obviously don't do a lot of birth control in my cancer care practice, but I will say almost every gynecologist I know has an IUD. And I mean, I think that says a lot. Like, you have the experts that basically, and obviously we work a lot of shift work and overnight things, and times where taking like a pill consistently can be problematic, but almost every gynecologist I know, and I know a lot of gynecologists, has had an IUD at some point.
And don't they ask you, that's going to make you fat? Isn't it going to make your skin bad? And is your hair going to fall? I'm like, really? Do you think? No. I mean, if I thought that, I'd let somebody else try it first.
There's a couple of really great things about it. So first of all, like what Dr. Pulaski was saying is that basically you don't have to think about it. You get it placed, and then you kind of just, I guess you have to remember, okay, I got it done in 2017, so in 2022, I got it taken out, but that's really where the extent of it is. Side effect-wise, it kind of depends on which one you get, but like a little bit of spotting is usually the worst thing that happens, and that's usually within the first 6 months of placement. But the convenience of it and not having to worry about everything is really just kind of top notch. And if you look at all of the different types of birth control out there, it really is one of the most effective. It's still better than tubal ligation. It was 99.3%.
It's definitely better than the pill, especially when you
better
take human error out of it.
Yeah.
There's nothing you can screw up about it.
I'm pretty sure that it's still rated better than a tubal ligation for preventing pregnancy. So,
and I still have women tell me that their older gentleman doctor said, you can't have one because you haven't had a baby. That is absolutely not true. That is so outdated. I don't know why that's believed, but really anyone can have it with few exceptions.
I have a question, but I wanted to jump on the IUD train. I'm a huge fan. No babies, and also heavy periods, heavy cramping. All gone. It's amazing. Yeah. Biggest fan right here. But speaking of the cramping, and going back to endometriosis, how do you determine if the issues behind period cramping are related to endometriosis, and how do you treat them?
Yeah, the definitive diagnosis is by laparoscopy, biopsy, actually getting a piece of tissue that shows that it's endometriosis. You don't necessarily have to go that route, though. A lot of people, they'll come in and they have symptoms that are very, very similar to what you would expect endometriosis to do. You try them out on a birth control, whether it's an oral birth control, you try them out on an IUD, you see if their symptoms go away. I have horrible endometriosis, and I got the IUD, and I mean, it was at a point where 5 days out of the month, like I'd be walking bent over, like trying to be in the OR and like having to have anesthesia give me some Toradol so I could operate for the day. So it was really bad. And then finally I was like, I'm getting the stupid IUD, like we're done with this. And within 2 months, I haven't had a single day of severe back pain since. So yeah, I mean, you start there. If you're struggling with your diagnosis, you do a laparoscopy, put in a couple of ports, take a biopsy, super easy day surgery. So,
I'm going to circle back to what we talked about earlier. Find somebody who listens to you. Endometriosis is, a lot of patients come to me and they've had the diagnosis and nobody ever explained to them what it means. It's just a word and they know that it means something bad, but they don't understand why they have it and risk factors and what that means. So if a lot of the diagnosis is made by good doctors listening to their patients. There's certain words we hear. The pain is typically cyclic. It is oftentimes worse with sex. They have worse pain with bowel movements. So there's certain things that I hear and I'm like, oh gosh, she's got that. It's not a GI disorder. It's not a bladder disorder. And so it's really sorting out the bad things and figuring out what it's not. And then once we're highly suspicious of endometriosis, we can either treat it empirically, which is just give the medicine and see if it works. And if it does, great. And if we're really struggling, then we put a camera in and do a minor surgery to definitively diagnose it.
Yeah, go ahead.
Can we talk about lubricants?
Absolutely.
Yeah. There's so many out there, and some are water-based, some are not. What do you feel are the most safe, healthy lubricants that we...
I'm going to answer this. There is nobody that works harder on the lubricants than Pure Romance. We want to make sure there's a lubricant. There's lubricants that are used whether it's you're pregnant or you're trying to get pregnant. So you have your water-soluble lubricants. If you're going to have anal sex, there's a different type of lubricant for that. If you're going to use a bedroom toy. So I think that maybe the doctors have other ideas, but I really do believe if you sit down with a Pure Romance consultant, she could really help you to define what type of lubricant you're looking for. How about that?
I agree.
yeah, totally agree with that. The only thing that I would add.
Well, you need samples. Ask and you shall receive.
The only thing I would add to that is that if you're going to use a lubricant, to try to avoid petroleum products, okay? So don't use Vaseline. It's not a good idea. It's going to cause, use a product that's meant to be a lubricant. Don't use, the butter in your fridge. It's not a good idea. I've had tons of patients, and they're like, oh, I got rid of all of my extra virgin olive oil, But yeah, no, use a product that is meant to be a lubricant.
I did go to my OBGYN and they did give samples of some lubricants. I'm wondering why Pure Romance hasn't gone into doing samples to different OBGYNs of different lubricants that they have.
We have.
Okay.
We do.
We have them in my office, and we sell some of their products out of my office. Okay. It's not on the front shelf when you walk in. You have to come and ask for it, but we sell some of that.
Because the lubricants that my OBGYN gave me were just
awful.
I
can answer that.
So I went back to her, to my dealer.
I have two questions. The first is, you talked about IUDs, but not an ablation. So I'm curious what your perspective is on that. Of course, obviously, if you're not planning on having more children. Right. And then I also am curious about your perspectives on women and weight gain and how that affects your sexual health. Do you recommend, what is the best recommendation? Because when I go to my gynecology appointments now, my doctor's like, oh, once you turn 35, you're going to gain weight. That to me is not acceptable. I would like another answer other than that.
We'll just go down the line. We'll go one by one. Okay, ablation. There's a lot of misunderstanding about ablation. It is not intended for contraception. It makes for an unfavorable environment in your uterus, so it might accidentally prevent some pregnancies, but I would never perform one without somebody having contraception in place. The intention for ablation is to burn the lining so that it can't regenerate, thicken, and bleed each month. So it is a really, really effective tool for heavy bleeding and painful menses. My rate of hysterectomy, or the rate of hysterectomies, went down significantly 15 years ago when ablations became commonplace. So huge advance in women's health. Good thing, but not for everybody. It's for problem patients. Weight gain. I do a lot of weight management as part of my wellness approach to taking care of the whole woman in my office.
People are wondering what ablations are.
Oh, ablation. Ablation is it's a procedure. There's different names for it, and we burn the lining of the uterus. It sounds terrible, but it's actually pretty relatively painless and very effective. Burns the lining sort of scars down effectively so that even though your hormones are still working each month, it does not affect your hormones. It mechanically changes the lining so that it doesn't thicken and bleed each month. So many women have lighter or even absent periods without hormonal modification. But again, it's not for birth control. It's intended for heavy bleeding. The weight gain, I do a ton of this in my office as just part of the bigger picture of what's going on with women, because you're right, it has to do with everything. Women who struggle with their weight, and almost everybody does, whether it's 5 pounds or 50 pounds, everybody's working at it at one point in their life. And women who struggle with their weight have higher rates of anxiety and depression, which then causes more problems with libido, which then feeds back to more weight. It's a terrible cycle, and it's far more complex than a lot of doctors are willing to admit. But there are tools, and again, if you have a good doctor who can listen to you, there's nutritionists out there, there's hormonal contributions. Women come to me all the time, and they're taking medicines causing weight gain, and they have no idea. There's also women who come to me and their thyroid is underactive, their vitamin D is low, and nobody thought to mention that. You're not morbidly obese, so they kind of blew it off. No big deal, you know? It's not about that. It's about feeling good, feeling confident, and staying at your best so that you prevent problems down the road. But you are right, it is complex and it is all related.
I'll say I don't know anything about ablations, but I just learned about that 2 seconds ago. And you're probably not asking me, but I will say body image and weight gain. I think it's really important for us to do self-affirmations and who we are today. So yeah, maybe we might want to lose weight, but to be able to say, man, I really like the shape of my breasts, let's say, or like, hey, my legs made me be able to, I am healthy enough to be able to work out today, and I want to be able to affirm my body in that. What happens is when we start to criticize ourselves, we tend to project that onto our partner too and think, they must think these things that I'm saying about myself. And so it starts to create some of that unhealthy sexual connection that we start to pull away maybe. And so being able to, even though we want these healthy goals, being able to affirm ourselves the way that we are today, I think is really important for our sexual health as well.
Oh, that's good. That's really good. You're so right. Thank you. I think everybody in here is like, yeah, I know.
And then as far as, so weight gain, I'm not going to talk about ablation because Sarah did a great job on that. And yeah, to reiterate, it's not for birth control. But from a weight gain perspective, so a lot of what I do in my office is counseling about weight loss for different things. Okay, so urinary incontinence being probably the biggest one. So the primary things in my practice are urinary incontinence and prolapse. Okay, I do a lot of pelvic pain as well, but bread and butter of urogynecology is urinary incontinence and prolapse, both of which are exacerbated by weight gain. And especially overactive bladder symptoms, there is a ton of data out there that says for every 15 pounds that you lose, your overactive bladder symptoms will become a magnitude better. And so a lot of what we counsel about with weight loss, it's hard though, because you've got an overactive bladder, every 30 minutes you have to pee. How are you gonna go for a run or go for a long walk? Like, you've got to pee. You're wearing a diaper so that you can go for your walk. So it's much more complex than that, but it is very much related to weight gain.
Hi there. When I was 65, I went to my gynecologist at UC And she told me I never had to have another pap smear. And when I asked her why, she said, by the time papillomavirus would show up, you would be in your 80s, and we would not treat you for cervical cancer. I was aghast because we've been conditioned over the years to have that pap smear every year. I haven't been to a gynecologist since then because I'm just confused as can be. And I think a lot of older ladies, I'll be 72 in July. I'm a proponent for IUDs. I used one through my whole life. I'm single, never married, and did not want to raise a child alone. So I have two things here, but I really like the answer to the cervical cancer and the pap smear.
I'll take that one. That's definitely in my wheelhouse. So I don't do ablations. But so I think one of the important things, and maybe we as a society from the ACOG perspective and all that have not done the greatest job as to explaining like what pap smears really are for, what the purpose is for the well-woman exam or an annual exam with your gynecologist. But your gynecologist is right. Current standard of care is to not do pap smears after the age of 65 if you meet low-risk criteria. And that low-risk criteria is that you haven't had significant cervical... Well, that's not on the list, but that might include it. But you haven't had significant cervical dysplasia in the 20 years prior. And over that 20 years, you've had at least 3 separate pap smears with co-testing, meaning they've tested you for HPV virus, or you've had at least 5 pap smears over the 20 years prior that were normal. So you have this long history of routine screening. The pap smear is designed to screen for cervical cancer. That's its job. And that's what is very unlikely if you've had a 20-year history of no high-risk precancerous changes of the cervix that you're going to get cervical cancer after the age of 65. Now, I disagree with them that if you had cervical cancer at 80, that we wouldn't treat that. That's a different modality. And if you had high-risk problems prior to 65, then we do keep screening, especially in patients with a life expectancy of more than 10 years. That's the real cutoff because cervical cancer is a really slow process. The time from like high-grade dysplasia on a biopsy to invasive cervical cancer on a timeline is probably on average somewhere between about 3 and 8 years. You don't have high-grade dysplasia today and cervical cancer next month. You have high-grade dysplasia now and cervical cancer 3 years from now when you didn't treat it. And so screening for cervical cancer at 65 doesn't make economic sense. We often overtreat. We find problems that then cause a lot of anxiety and stress for things that aren't actually going to become a cancerous problem. However, just because you're not having a pap smear doesn't mean that you don't need a trusted gynecologist in your corner. I mean, all of these issues that we're talking about with, libido, desire, hormonal replacement, lichen sclerosis, vaginal health, vulvar health. I see a lot of skin cancer of the vulva as women age, and most of them haven't seen a gynecologist in decades. It is also a very, very slow growing process. And so we're doing more down there than just a pap smear, and
we should be.
Yeah, we should, yeah. So I think that's the real discrepancy is we get a tide, and I love taking care of women. I'm so grateful for the process that we do, and I explain when I talk to my husband or other men about it, I say the difference is that women get tied to a physician very early in their lifetime because either they're pregnant and they need a physician or they don't want to get pregnant and so they need a physician. And so they get very tied into the process of having a healthcare provider very early on, and it makes them amazing patients for the duration of life. Versus men, you have to drag them in, kicking and screaming, because they just don't associate the need for routine healthcare. So, but there's more to routine women's healthcare than just a pap smear. But I will say the whole women's health exam annually is also not to deal with your chronic pelvic pain. A good provider is not blowing you off when you come in for your well woman exam and you say, well, I really want to talk to you about my heavy periods. That's a problem visit. That's out of the scope of the general routine annual health. And so they should say, well, we can deal with that today, or we can deal with your health maintenance today, and then we'll deal with that at another appointment. So they're not trying to push you away, but there's so many things that we have to put in the component of health maintenance, and we have limited time period for exams and appointments that they're trying to grab that in. But your doctor is correct. There is very good screening guidelines for when to stop pap smears. and they're accurate and follow.
We have a question up front.
We have one back here first, sorry.
Oh, okay.
Go ahead. Are you sure? Yeah. Okay. All right, let me first preface this by saying I really, really hate heteronormative, like, penetration-focused definitions of sex. And I certainly with like my children, I have a boy and a girl, I'm trying to get them to sort of think of sex much more broadly, and that's sort of a message I try to preach. That said, I'm one of those people, I think she asked it before, who as a teenager and in my 20s, actually before I ever had intercourse, experienced a lot of vaginal pain, and even like just using a tampon was like really, really difficult. It was something like I came from a like very conservative Hispanic family, and you didn't really talk about this stuff. But when I would try to talk to physicians, when I finally kind of got up the nerve to do it, people were just really dismissive. And I know that's not shocking, right? But a lot of people would say, "Oh, well, it's just the way you're shaped, whatever that meant, or you have a short vagina, or your cervix is tilted," or whatever. And I had no idea what that actually meant, or whether any of this was fixable. So my question is, to what extent, for people who do experience pain upon insertion of, well, let's just say about almost anything, how much of it like can be physiological in terms of like someone's shape, and like what kinds of treatments, and maybe this is too broad of a question, but if you can just kind of answer generally, are there treatments if there's something where it's like the way that they're just structured might be causing some of those issues?
Can I start by saying sex just shouldn't hurt? It really shouldn't. And there's something wrong, and even if it's not a physical thing, then maybe you need a lubricant. Maybe you're not connecting with him to tell him what feels good for you and how you want it. But it shouldn't hurt. It should be something that feels good and you want to do it. And that's why it's a healthy behavior too, endorphins and all of that. When women come to me with painful sex, I first have to delineate. I think Dr. Evans is probably the same way. Oh gosh, what does that mean? Well, is it in the beginning, or is it deep sex, or is it somewhere in between? And that's a really important distinction anatomically in terms of what disease process. I have young girls who have partially or completely intact hymen. That's gonna hurt. They can't use a tampon, they certainly can't have sex, they're afraid of touching, and that becomes a snowball effect. That is an easily treatable thing that we do all the time, and life-changing for those girls. And I'll see girls in their 20s who said, "I've never worn a tampon," because you don't want to or because you can't? Because I can't. Well, let's fix that. There are the Patty Brisben Foundation for Women's Sexual Health has 4 sort of main areas of focus, and one of them is vaginal pain disorders, so vulvodynia and vaginismus, which are 2 very big words, but basically pain on the outside and pain on the inside. And oftentimes those are pain syndromes related to involuntary contraction of the muscles. So even though your brain might be in the game and you're like, okay, relax, this feels good, I want this, your body's not doing it. And it's tightening up and it causes pain, which then makes you not want it. There are treatments for that. Janelle does some of the more advanced treatments. There's a lot of different treatments, but you have to find a doctor who can kind of delineate, is this as simple as a hymen procedure, or is it something like endometriosis? Is it something else in between? Where is the problem? And then kind of direct the treatment based on that.
Yeah, and vaginismus and vulvodynia, like you were saying, it's a very complex situation, and there's a lot of different treatments for it. From a vaginismus standpoint, the vast majority of vaginismus is caused by pelvic floor spasm, and like I was saying previously, PT. I mean, it's like, it's a godsend, it really is. There's lots of other things you can do. I mean, there's Valium suppositories for the vagina, which sounds crazy, but it actually really works. Yeah. There's different dilator therapies, all of that kind of
Pure
stuff.
Romance makes dilators that are
great dilators. And they're so much cheaper than the ones that you buy from like the medical device reps. It's like 1/5 of the cost. So if you need dilators, get the Pure Romance ones, because they're much cheaper. But there's so many things that can cause pelvic pain when you're young, and I can say, like, even in the last couple of weeks, I've done a couple of Botox injections in the pelvic floor because people have failed 10 different treatments. And even that, now finally insurance is actually covering that, which they hadn't until about 1.5 years ago. So there's more and more treatments. It's just a matter of getting in with the right person that knows how to work that up and figure out what the underlying issue is. So.
And I mean, you said you came from a Hispanic culture, and I think a lot of times I immediately refer to a pelvic floor specialist, a sex medicine doctor, to find out, what can we rule out and what's here. But a lot of times anxiety or cultural shame that we put, like, that ends up happening. Like, I'm a bad person if I engage in sex before marriage, or my parents told me I can't get pregnant, so now whenever I think about having any kind of insertion or anyone near my vulva, I start to tighten up. And so what happens too is that our brain, whenever we think of a sexual stimuli, or if we become aroused, our brain starts to say, shut it down, shut it down. And so one of the first things to clench is the pelvic floor area. And so we can almost naturally start to lock ourselves up to create some of that pelvic pain. So along with pelvic floor therapists, sex medicine doctors, it's really important to identify what messages do I have about sex, and how am I interpreting that? Like, how is that translating into my body too?
Hi. A few years ago, I was diagnosed with PCOS, and I have pain during my period, and I just always associated it with that. But then a few years ago, my mom had a hysterectomy, and she found out she had endometriosis, but she had never had any symptoms, and I don't know if that's just because she ignored them, but she never vocalized any symptoms. And so my fear is that, like, I don't feel like I have extreme pain during my period, so I don't want to be like, oh yeah, I have endometriosis, that's the pain. But like, she went so many years undiagnosed, is it still worth getting checked out, or is it just PCOS pain?
Anytime you have any sort of pain, especially if it's cyclical pain, it's definitely worth getting it checked out. I mean, you have PCO, so you have a reason to have some level of pelvic pain, but it doesn't necessarily mean that that's the only thing. And there is a genetic component to endometriosis. Having your mom say, like, oh, I really didn't have symptoms, some people don't. Some people have like horrendous scarring and stage 4 endometriosis with like big cysts everywhere and all that stuff, and they feel fine, but then other people have one tiny little spot of endometriosis on one of the ligaments in the pelvis, and they're in excruciating pain every time they have a period. So just because you don't have a ton of pain or you have a ton of pain doesn't necessarily correlate with the stage of endometriosis. So.
Gardasil was something that was real popular years ago. Cervix cancer, HPV was very normal, I guess, in my family. I received that shot. Have you ladies, like, people are telling me to be cautious now, that they did reading. I personally haven't had any problems, but do you guys deal with women who are actually having any issues from 10 years after getting it, as well as, I'm sorry, it's kind of like two parts.
I see women that have problems from not having the vaccine, but no, a lot of it's the vaccine trouble, like, in this country. I mean, that gentleman, I won't use the word physician, that published the falsified data about the MMR and autism has really ruined vaccines, I think, for generations to come. But the HPV vaccine is safe. There's been more than 270 million doses given worldwide over the last 20 years. There's no increased adverse risk, and the VAERS reporting close clinical data, research data, randomized trials where the highest, exactest of science is done. What you're getting now is the social media feed. And you get this little press of, well, maybe. There's no association with infertility, there's no association with autoimmune disorders, there's no association with neurological changes, there's no association with early death. It is a safe and protective vaccine, and if nothing else I say tonight means anything, everybody should have it. I mean, it is more than 90% effective for preventing HPV-related cancers. I mean, it's a cancer-preventing vaccine that's safe over decades.
It's going to change a generation.
Yeah,
really.
I mean, I'll be out of a job from a cervical cancer perspective, and I will be grateful for that.
Let me add to that real quick. As scientists, which we all are, it's kind of our job to figure out the evidence. And unfortunately, you guys are exposed to so much with social media that you don't know who to believe and what to believe, and you're hearing all the bad stuff, and that's what sticks more than the good stuff always. There is correlation and there is causation. These are words we use all the time. So somebody might say, my kid had a seizure right after the Gardasil shot. That might be, but it doesn't mean it caused it. And that's a really tricky thing for the average non-scientist to put together. So I mean, that's really for your doctors to kind of sort out for you. Like the IUD, I tell everybody, I gave myself the Gardasil vaccine. I was way too old to get it according to the FDA, but I was like, I'm single, it's only gonna help me. I signed up for it. So, yep.
So is there an age as far for younger women, like to start it? Like my niece, my sister's daughter, my niece, she said she's been asking questions about it. Yeah, and she's 13. So is there a certain age or anything?
It's actually 11 or 12. It's FDA approved for boys and girls from the ages of 9 to 26, and that's because that was the age range studied. And the other thing you have to know about vaccine medicine is it's population prevention. So where can you get the most bang for the buck? So more than 90% of adults have been exposed to HPV. Now, who gets chronic HPV infections? We really don't understand why that is. And it's patients with chronic infections that become our cancer patients. Most patients have the virus and clear it, but more than 90% of adults will have had HPV. It's not something you can avoid by being a good girl or making normal decisions or not having sex before marriage. You have any sort of sexual touch with a partner who's had any sort of sexual touch with someone else, you have had HPV. And so they recommend the best and most effective endurance of the vaccine is for girls and boys prior to any sort of sexual exposure. And it is sad in this day and age that 11 and 12 is where we need to catch that, but that is true. There also seems to be an increased duration of response to kids under 15. If you're under 15, 2 shots seems to give the same protection as 3 shots over 15. And so the recommendation changed about 1.5 years ago that if you're under 15, you only need 2 shots 6 months apart, versus if you're over 15, then you need 3. And yes, as a OBGYN resident over the age, could you take the vaccine? Of course. As a single person, it's protective. Is your insurance going to cover it? No, because it wasn't FDA, it's not FDA approved for that indication because they're trying to give the most vaccine to the population that's going to offer the best protection. So there are certainly patients outside of the recommendations that might gain benefit from either catching up or from having the vaccine when they weren't offered it. But the best and protective is actually to combine the vaccine, and the way we get the most acceptance in practice is to combine it around 11 or 12 because that's when our preteens need their Tdap and their meningococcal vaccines. And so it's the easiest in terms of, I think, acceptance from a population standpoint and from a patient standpoint, just to couple them all together. Now, I will say, as a former gynecologist, I think you do need to use that opportunity as a time to talk about your values about sexual relationships with your children, whatever that is, whether it's whatever values you want to put on them. That's the conversation when it needs to start before they're much older and they're too embarrassed to talk about it. But absolutely, 11 to 12, 13 is fine, under 15 is ideal, but even up to age 26, you're going to get your insurance at least to cover it.
Well, right now, I'm going to tell you what, are these doctors amazing? Do you feel like, yeah, big round. I love this platform, and I am so grateful and thankful to each and every one of you who were brave and opened up and asked questions, because I think that it's so empowering to, have this knowledge and to be able to pay it forward to others. And I hope next time we're going to do this again. So you want to put this on your calendar for September 26th. We will be sending out information where we're planning on having it. We don't have that place yet, but it'll be, I think we're looking at Queen City Club, I think, right now. So it's the 25th. Tuesday night, 25th, we'll have it again at the same time, 6 o'clock. So again, thank you for being brave. And there's note cards on your chairs. So if we didn't get to your question, or you didn't feel brave enough to raise your hand, please fill out that note card, because our panel here, our doctors here, so they're willing to take these questions and answer them. And then we will have them up on our website, which is the pattybrisbenfoundation.org. Give us about a week, and then we'll have these up. I am grateful and thankful to have this speaker series. I'm looking forward to the next time. You guys did an amazing job tonight, and I don't think there's any place else that you could have went here in Cincinnati and had doctors that spent this much time giving us the information that we deserve. And I'm sure that there's many of you sitting out there thinking, I think I need a new doctor.